Cool. So welcome everyone to our finals crash course series on psychiatry, taught by Dr. Sophie. If you look on the left side of the screen, you've got our email, so feel free to email us with any questions about the session today or just any questions at all, feel free to email. And on the top right is our Instagram page. So if you follow that, you can get all the information about our sessions coming up and things like that. And if we go to the next slide, so this is the link to the polls for today. So if you just scan the QR code, and I'll make sure I put the link in the chat as well. So I'll give you a few minutes to join. Have you started the session, Sophie? Let me just.
Is it? Sorry.
Yeah, you have. Sorry, mine was still not loaded yet.
No, it's fine.
Perfect. I'll post the link in the chat if anyone's missed it, but I think we're probably good to go.
Yeah, thank you very much. So yeah, good evening, guys. My name is Sophie. I'm currently an F1. My first job was in psychiatry, and so I've agreed to do some of these sessions to hopefully impart some knowledge and help you guys brush up for finals. I'm going to turn my camera off from this point onwards because I have terrible internet and I want you to be able to hear what I'm saying as opposed to see me. So hopefully that will work. If there's any issues with connectivity, just let me know. And if throughout there's any questions, again, let me know. Either pop in or you can unmute yourself and ask your question, as I think there's only a couple of us here today. So we're going to cover a few things in today's session. So we're focusing on psychosis and the Mental Health Act. So we'll spend some time looking at schizophrenia. We'll then move on to look at how we treat schizophrenia, including the use of antipsychotics. We'll then spend some time going over the Mental Health Act, before finishing up with sort of a few bits and bobs, looking at some terminology that we use in mental state examinations, what it actually means. And then we'll touch briefly on some of the weird and wonderful psychotic syndromes, and also a little bit on hallucinations as well. So question one, hopefully you guys have now all got the polls up on your phone. So you're an F2 working in psychiatry. A 21-year-old man and his mum come into your clinic. For the last 6 months, his mum reports her son has been increasingly withdrawn, spending large periods of time alone in his room. He's stopped going to work and has reported that there are people who are out to get him. He's not been tending to his personal care, and he's been doing things he wouldn't normally do, saying he felt like these actions weren't his own and he had no control over it. She's also noticed him muttering to himself, and when she asked who he was talking to, he said it was the 2 men, but there were no 2 men around. You suspect a diagnosis of schizophrenia. So which of Schneider's first-rank symptoms is this patient displaying? I'll give you guys a few minutes to read that through again and answer, because I know it's a bit of a chunky question. I'll just give a couple more minutes, or seconds rather, to see if we've got any other answers coming in. So the correct answer to that question there, which is a little bit of a tricky one, was actually E, so auditory hallucinations and made volition. So Schneider's first-rank symptoms are symptoms that we see that basically means a diagnosis of schizophrenia is more likely than some other kind of psychotic disorder. So it doesn't mean that they're the only symptoms we see in schizophrenia. It just means that if these symptoms are present, it's more likely a diagnosis of schizophrenia than some other form of psychosis. So we can split Schneider's first rank symptoms up into sort of different categories. So we've got our auditory hallucinations. So these are things like audible thoughts, voices arguing, running commentary. We can then think about our thought disorders. So these are thought withdrawal, insertion, broadcast. We can then group together our passivity phenomena, which are things such as made volition, made affect, and made impulse, and somatic passivity. And then finally, we've got our delusional perceptions as well. So I think sort of the auditory hallucinations, what they are quite self-explanatory. I think with the thought disorders, they're also quite self-explanatory too. I'll just go through sort of the passivity phenomena to just explain what some of those are, as I think that's sometimes where the confusion can be. So when we talk about made volition, this is when the patient experiences their actions as being under the control of an external influence. So they feel like what their body and what their actions that they're actually doing, they don't feel like that's necessarily what they want it to do. Sort of a similar thing happens with made affect, which is where they feel emotions that they don't really recognise or experience as one's own. So it's like somebody else has, given those emotions to them. And then with made impulse, this is where the patient experiences kind of a drive and a motivation to complete an action that again they don't feel like that drive is coming from them. It feels alien to them almost. And with made impulse, they might get sort of this drive to complete an action, but they might not necessarily actually complete that action. And then I think the final thing to sort of clarify on this slide is probably our delusional perceptions, which is different to delusional thinking. So a delusional perception is actually a true perception, but it's something to which a patient attributes a false meaning. So for example, if the patient is walking in the street and they see the traffic light turn red, and they interpret that the traffic light turning red means that aliens are going to land. So it's true that the traffic light has turned red. That is very much a true perception, but it's just what they've interpreted that to be that's delusional in nature. So your delusional perception is different to your delusional thinking, which would be things like thinking you're the King of England, or thinking you've won the lottery, or you're the richest person on earth. So coming back to our STEM question here, we can see that actually persecutory delusions is not the same as delusional perception. So that's why that answer is not correct, which I think sort of caught a couple of people out. And we'll move on to explain why it's not some of the other answers. So although we have our first rank symptoms, oh, sorry, was there?
Hiya, sorry, just letting you know, we had one question in the chat. I think it was before you started your explanations earlier, but someone asking, is made volition the same as passivity? I can't pronounce my word. Passivity phenomenon.
Yeah, I mean, I've kind of always understood that they are basically a very similar thing. I was trying to think through when I was going through this whether there is kind of any massive difference between the two, but I didn't come across that there was really. It is to do with that idea that, your actions are being controlled by an external influence. So hopefully that helps, and hopefully having sort of explained through what each one of those things are after that question came in has also helped clear things up. But yes, so although we've got our first rank symptoms, we obviously have other features of schizophrenia too. So these are things such as impaired insight, neologisms, which is where patients kind of make up their own words. We can also see catatonia sometimes in schizophrenia. So this is where the patient's brain is sort of in such an excited state that it just completely freezes. So these are the patients that are very still, they don't eat, they don't drink, they don't talk, and they can get quite sick because of those reasons, obviously. And then with schizophrenia, we also have our negative symptoms as well. So these are things like our blunting of affect, our anhedonia, so our lack of motivation, alogia, which is poverty of speech, and avolition, which is poor motivation. So again, coming back to the question, I think a couple of people selected C as the answer, which isn't wrong because the patient is displaying anhedonia, but obviously the slight sort of trick was that anhedonia isn't considered one of Schneider's first rank symptoms. So although that was a symptom that was present for the patient, it's not counted as one of our first rank symptoms. Okay. So sticking with the same sort of case then, 2 weeks later, the same patient returns. So his mum reports that since his diagnosis, she's been doing some reading on schizophrenia, and she tells you that she's read that it's caused by an imbalance of dopamine. She's a little bit confused about what she's read about different pathways, positive and negative symptoms, and increased and decreased levels of dopamine. Which of the following statements are true? Again, I'll give you guys some time to read through the answers and then pop it into the poll what you think it could be. Just give a couple more seconds. So the correct answer to this one is option A. So negative symptoms arise due to decreased dopamine in the mesocortical pathway. So we'll launch into some hardcore neurophysiology here. So we've got 4 main dopamine pathways that we see within the brain. So these are the mesolimbic, the mesocortical, the nigrostriatal, and the tuberoinfundibular. And what these pathways basically mean is that we've got a load of dopamine neurons that are connecting one part of brain to the other. So in the mesolimbic pathway, we have our dopaminergic neurons, which are originating in the ventral tegmental area, and they're projecting to the nucleus accumbens. And this pathway is reliant upon our dopamine 2 receptors, and it's responsible for motivation, emotions, and reward. So we know that schizophrenia is caused by an imbalance of dopamine, and when it comes to the mesolimbic pathway in schizophrenia, we see increased dopamine levels, and it's these increased dopamine levels within this pathway that result in the positive symptoms of schizophrenia. And because this mesolimbic pathway is reliant upon our dopamine 2 receptors, that's why when we use our dopamine 2 antagonists, that we reduce the positive symptoms of schizophrenia, as we're reducing the amount of dopamine firing in that pathway that's causing the patient's positive symptoms. So the mesocortical pathway is the pathway where we've got our dopaminergic neurons projecting again from the ventral tegmental area, but this time they're going to the prefrontal cortex. And this pathway is reliant upon our dopamine 1 receptors. And it's the pathway responsible for cognition, executive function, emotions, and affect. And here in schizophrenia, we actually have decreased levels of dopamine within this pathway, and that's where we get our negative symptoms from. And so by using our partial agonists, which is properties that some antipsychotics have, we help reduce the negative symptoms of schizophrenia, as within the mesocortical pathway, we're increasing the amount of dopamine on that pathway. So on the left-hand side, there's just sort of a couple of schematics that will hopefully help you guys get your head around it a little bit. So the one at the top is showing our different pathways and what part of the brain they reach from and to. And then the little diagram at the bottom is just running through sort of how dopamine is, as a neurotransmitter, what it comes from and how it's released. So it sort of comes from tyrosine, which gets taken up and converted by tyrosine hydroxylase into DOPA, and DOPA is then converted to dopamine by our DOPA decarboxylase, and those vesicles of dopamine are then obviously released at our presynaptic neuron, and they bind to our postsynaptic neuron, and that's how it works as a neurotransmitter. So it's the mesolimbic and the mesocortical pathway that are sort of the two main pathways that are involved in the pathophysiology of schizophrenia. I'll just briefly touch upon the nigrostriatal and also the tuberoinfundibular too, because they also sort of help explain a couple of things. So with our nigrostriatal pathway, we've got our neurons projecting from the substantia nigra to the caudate and putamen. And this is the pathway that's responsible for our motor planning and stimulation of purposeful movement. So in the way that we mentioned earlier that we can use our D2 antagonists to help reduce our positive symptoms by blocking all that extra activity happening in the mesolimbic pathway, when we do this, we inadvertently get the side effects of extrapyramidal symptoms, and that's because our D2 antagonists are blocking the dopamine that would normally be running in the nigrostriatal pathway to enable us to do purposeful movement. So that's why when we have extra dopamine within this pathway, we can see our extrapyramidal symptoms. And then with our tuberoinfundibular pathway, which connects the hypothalamus to the infundibular region. So in this pathway, when we have dopamine present, it inhibits prolactin release. So when we've got our D2 antagonists, it's stopping that inhibitory effect on prolactin. And as a result, we see an increase in prolactin levels as a side effect of the medication, which we will come on to talk about a little bit more in a second. So part 3, following on from this same case, is the mother asks if there is anything that she or her son have done which has caused him to develop schizophrenia. So which of the following is considered the strongest risk factor for development of schizophrenia? So we've got cannabis use, family history, social deprivation, living in a city, or gender. Just give a bit of time. Okay, perfect. I think everybody's answered there. So the correct answer to this one was B, family history. So obviously there is a number of risk factors for schizophrenia. And the lifetime risk of any one of us developing schizophrenia is 1%. So that basically means the chances of you getting it over your lifetime is 1 in 100. And if you're going to get schizophrenia, it's most commonly going to develop between adolescence and your mid-30s. The strongest risk factor for schizophrenia is genetic predisposition. So if you've got a twin who's got schizophrenia, then your chance of having schizophrenia goes from that lifetime risk of 1% up to 50%. If you've got a parent with schizophrenia, then your risk is increasing up to 10 to 15%. And if you've got a sibling who is not your identical twin, then you're looking at your risk increasing up to about 10%. So although family history and genetic predisposition is considered our strongest risk factor, we've obviously got lots of other risk factors lots of other risk factors present, including things like abnormalities of pregnancy. So if your mum got flu in the second trimester, that's apparently a risk factor for schizophrenia. Things like Black Caribbean ethnicity, migration and winter birth are also risk factors. And I've grouped those ones together because they think it's to do with sort of the impact of vitamin D and that potentially causing schizophrenia. So obviously with migration with birth, Black Caribbean ethnicity, sort of decreased light levels in the winter is going to lead to decreased vitamin D. With migration, if you've come from somewhere that's a lot sunnier and then you're coming to somewhere like rainy England, again, decreased vitamin D, and then Black Caribbean ethnicity, obviously requiring higher levels of vitamin D, higher levels of sunshine, sorry, in order to generate vitamin D. So they are some of our risk factors there. So we'll move on to a different kind of case now for question 4. So question 4, you are an F1 working in liaison psychiatry, and a 76-year-old lady with a diagnosis of schizophrenia has been referred to your service. After changing sheltered accommodation, she appears to have been lost to community follow-up and hasn't been on any medication for several months. Your consultant wants to reintroduce olanzapine, as it appears she was previously well controlled on this. So according to the BNF, which of the following tests need to be arranged prior to starting medication? For this one, feel free to obviously use the BNF. I know for you guys, it's probably coming up to PSA time, almost. So this can be a nice bit of overlap revision between learning how to use the BNF and also a bit of finals knowledge. So again, I'll give a few minutes for you to pop down your answer for that. Just a few more seconds. Okay. So the correct answer for this question is C. So when we look at the BNF and when we look at monitoring requirements, these are the blood tests that they want to happen before we're starting a patient on olanzapine. It's also mentioned within the BNF that they recommend that an ECG is also taken if cardiovascular risk factors are present. So obviously in this STEM, we don't have a huge amount of information about the patient's past medical history and whether there might be these cardiovascular risk factors. In reality, you'll probably find that actually all patients get an ECG done before being started on an antipsychotic, as better safe than sorry. And obviously, if we've got someone with a prolonged QTC, the last thing we want to be doing is popping them on an antipsychotic, which is just going to make that even longer and obviously potentially cause them a lot of problems. So dependent upon which antipsychotic you're looking at probably depends exactly what monitoring requirements you have. But generally the things that we're sort of going to do is things like our physical history and examination. We want a blood pressure and pulse, weight and height, selection of blood tests, and then our ECG, as we have already mentioned. With antipsychotic therapy, it's generally thought that monitoring should happen around 1 month after starting treatment. We then want to check in with our monitoring around 3 months, and after that it can be done annually. And that's for most antipsychotics. There are some exceptions which we'll come on to talk about a little bit later, but generally the BNF is sort of your go-to guide for the exact monitoring requirements for whichever antipsychotic a patient might be on. So our antipsychotics that we use to treat schizophrenia can be broadly split into 2 different classes. So we've got our typical antipsychotics, otherwise known as our first generation, and then we've got our atypicals, which are our second generation. So your typicals, the ones you're probably most likely to have come across are things like haloperidol and cloprimazine. And then the atypicals, which tends to be what we use a lot more frequently now, are things like aripiprazole, olanzapine, clozapine, risperidone, paliperidone, and also clozapine. So sticking with thinking about medication and antipsychotics, we'll move on to question 5. So a patient with a diagnosis of schizophrenia attends your clinic for a medication review. She's previously been on risperidone and is currently on aripiprazole, but neither seems to have controlled her symptoms as she remains believing her neighbour is trying to murder her, she can hear voices and believes MI5 is stealing her memories. So you inform the sister who's present at the consultation that you think it could be worthwhile trialling clozapine. The sister is happy with this as a plan, but asks what side effects are associated with clozapine. So which of the following is it most important to warn her about? Okay, I'll just give a few more seconds in case anybody else wants to pop in their answer on the poll. Okay, we'll stop that one there then. So the correct answer for this, which I think people got, was C, agranulocytosis. So clozapine is our go-to drug when we've got someone with treatment-resistant schizophrenia. And treatment-resistant schizophrenia is defined as when a patient has had unsuccessful therapy with 2 different antipsychotic drugs, which have been trialed for 6 weeks each. So clozapine is a really effective drug, which is why, we find that it's good for these patients for whom other antipsychotics hasn't worked. But although it's very effective, it has quite a nasty side effect profile. So lots of things that clozapine causes: sedation, hypersalivation, can mess around with your blood pressure, cause weight gain. And as we've mentioned within the question, it can cause agranulocytosis. And that's the thing that we really want to be warning our patients about and that we want to be taking seriously. Because it has this long list of side effects, it's got a long list of monitoring too. So we're looking at our prolactin. Obviously, we mentioned earlier how the tuberoinfundibular pathway is affected by our antipsychotics and how it can cause increased prolactin. Because of the risk of agranulocytosis, we want to be doing regular FBC monitoring. So for the first 18 weeks, you are going to be taking that FBC once a week to check for agranulocytosis. Between 18 weeks and 1 year, you're still going to be testing regularly, but it will be about every fortnight. And then once you've passed that 1 year mark, you can just do your FBCs once every month. So slightly less frequently, but still quite frequently in the scheme of things. And the reason we have that initial really increased period of monitoring of FBC and white cell count at the beginning is because the risk of agranulocytosis is greatest in those first 18 weeks. And after 1 year, this significantly reduces. And after 2 years, it reduces even further. So if you've got a patient who's going to develop agranulocytosis, it's probably going to happen within those first 18 weeks. And that's why we like to stay on top of the monitoring to obviously make sure that we're going to pick up on that. As with lots of our antipsychotics, we want to be looking at lipids and weight because, these medications really sort of mess with our metabolism. And then we also want to be looking at our fasting glucose too. So we've spoken a bit about the side effects of clozapine. We'll now just move on to talk a little bit about the side effects of our first generation antipsychotics. So we can group those into sort of time as to when the side effects occur. So within hours to days of starting someone on a first generation antipsychotic, so these are our old ones, things like haloperidol, we can see things like acute dystonia or akathisia. So acute dystonia is basically where we have these involuntary contractions of muscles in the face, in the body, and these muscles contract either in like a sustained pattern or in an intermittent pattern. And this basically results in the patient having abnormal movements or abnormal posture. akathisia is defined as a patient who feels like they just have this inability to remain still because they have this inner restlessness. So with acute dystonia, the muscles are, actually contracting of their own accord, whereas with akathisia, the patient themselves is voluntarily moving, but they're voluntarily moving because they've got this inner feeling of restlessness that they just can't control. Within weeks to months, we can see our Parkinsonian type symptoms with our first generation antipsychotics. So these are often referred to as our things like slowed gait or shuffling, pill rolling tremor, rigidity, things like that. And long-term patients can develop tardive dyskinesia. And this is similar to acute dystonia in the sense that we've got these involuntary movements because of muscle contractions. But whereas acute dystonia affects muscles within the face and the entire body, with tardive dyskinesia, it just tends to be within sort of the face, eyes and mouth. So this is where you can see things sort of like your abnormal lip smacking and stuff like that. So if we've got someone on a first generation antipsychotic who begins to develop these extrapyramidal side effects, obviously we'll think about whether we can potentially change that antipsychotic, whether we need to decrease the dose. But of course, for some patients, actually, that first generation antipsychotic is the only thing that works for them, in which case we find that we have to balance the extrapyramidal side effects with the positive impact it's obviously having on the patient's mental health. And so it's here that cholinergic antagonists such as procyclidine can be really useful because they can help with those muscular side effects, whilst also obviously ensuring that the patient can remain on the antipsychotic in order to have improved mental health. And then our second generation antipsychotics tend to have quite a different side effect profile. So I think we've touched upon this already a little bit, but these are the ones that generally we see weight gain, impaired glucose tolerance and dyslipidemia, and that links into why we want to make sure with our monitoring we're looking at blood pressure and weight, our lipid profile and also our fasting glucose. The final thing it's probably worth sort of covering when thinking about our side effects of antipsychotics is neuroleptic malignant syndrome. So this is a kind of syndrome, a collection of symptoms including fever, rigidity, tachycardia, confusion, and this sort of fluctuating consciousness and blood pressure. So when you've got a patient presenting with these features and you know that they are on an antipsychotic and maybe there's recently been an increase in their antipsychotic or they've recently stopped taking their anticholinergics, then neuroleptic malignant syndrome is something you want to think about. And when we've got someone who we suspect might have this syndrome, then we want to be taking some blood tests. So we'll want to look at the FBC, where we tend to see raised white cell count. We want to be looking at their LFTs, which are just generally quite deranged and abnormal. And then we also look at CK, creatinine kinase, which is also raised. So moving away from schizophrenia and antipsychotics, we'll now focus a bit upon the Mental Health Act. So you're a final year medical student studying for your finals and you're revising the Mental Health Act. Which of the following statements best describes Section 3 of the Mental Health Act? Just give you guys some time to answer that. I think we've just had somebody join us, so I think we've got the link in the chat for the polls to answer the questions, and any questions at all, obviously drop it in the chat or you can unmute yourself. Okay. All right, so we'll stop that one there. And as was correctly identified by you guys, so the answer to this one is B. So the Mental Health Act is our main piece of legislation that we use in psychiatry, and it applies to everyone regardless of age. The main principles of the Mental Health Act is that we want to be doing the least restrictive thing possible. We want to respect diversity, include the patient in everything, and promote fairness, efficiency, and effectiveness. When we're thinking about whether somebody is able to be detained under the Mental Health Act, commonly referred to as sectioned, then there are 3 criteria that we need to meet. So number 1, we need our patient to be suffering from a mental disorder. And the mental disorder is actually quite a broad definition. It basically means any disorder of the mind. So this potentially includes things such as delirium or states of confusion secondary to substance misuse. It also includes things like personality disorders. The only thing it doesn't really include is learning disabilities. Learning disabilities can only sort of be considered under the Mental Health Act a mental disorder if the patient has also got sort of abnormally aggressive or seriously irresponsible conduct associated with their learning disability. So for someone with a learning disability, it's probably your Mental Capacity Act, for example, that might be more appropriate than your Mental Health Act. So when we've established that the patient's got a mental disorder, that disorder needs to be of a degree which warrants compulsory admission. And the reason it warrants compulsory admission is because without treatment, it's likely that they would seriously harm themselves or other people. So they're the things that we're thinking about when deciding if somebody should be detained under the Mental Health Act. So you're a medical student and you're placed on a geriatrics ward. And an 82-year-old woman has recently been admitted following a fall. During admission, she's been expressing persecutory delusions about being imprisoned, her food being poisoned, and the nurses wanting to kill her. So bearing in mind she's showing this disorder of the mind, and we're worried about the impact this could have upon herself and other people, a Mental Health Act assessment is arranged. Which of the following professionals need to be involved in order for a Section 2 to be completed for this patient? Okay. Last few seconds if anybody wants to pop an answer in. Okay, we'll leave that one there then. So the correct answer to this one was D. So we need to have 2 Section 12 approved doctors and an approved mental health practitioner. So when we talk about Section 12 doctors, these are basically doctors they've received special approval and that they know what they're talking about, and they are able to see if somebody is detained under the Mental Health Act. When we talk about approved mental health professionals, this encompasses lots of different professions. So it could be a social worker, it could be an OT, it could be a psychiatric nurse, a psychologist, and these people have also had requisite training for them to be able to make these decisions. And then when we talk about the nearest relative in the Mental Health Act, this is the person, as the title implies, that is the closest relative to the patient. And this person has some rights. So they have the right to be able to request an assessment for detention. And they also have the right to appeal if their relative has been detained and they think that this has been unduly done. But it's important to note that the nearest relative does not necessarily have automatic rights. So although they can request these things and they can appeal, if their relative is under the Mental Health Act, they don't have any automatic rights. So I won't sort of labour this point too much. Obviously, there's a lot of text on the screen. I'll leave you guys get access to the slides at the end of the session when you've done the feedback form. So I'll leave it there as kind of a memory aid that you can go back to. But this is basically just talking about some of the main sections of the Mental Health Act, what they are, which members need to be involved for that section to be done, and how long it tends to last for. So the sections that you're probably most likely to see as an F1 or even as a medical student is probably your Section 2 and your Section 3. So your Section 2 is when we are detaining someone to assess them, and Section 3 is when we're detaining somebody to treat them. And again, perhaps another section that you might see, particularly if you're working in A&E, is a section 136, which is a power given to the police. So if somebody is basically displaying abnormal behaviour in a public place and the police have suspicion to believe that the person could be suffering from a mental disorder, they are able to detain them under the section 136. They can get brought into hospital. Section lasts for 24 hours. So within that 24-hour period, they need to be seen by a psychiatrist who will then decide if the patient is appropriate for detention, in which case they'll get in contact with an AMP and another section 12 doctor, or whether the patient isn't appropriate for detention, in which case the section 136 will be discharged and the patient can just go about their life and whatever they were doing previously. So yeah, that guide, I won't read through all of it, but it's there for you guys to refer back to at the end of the session. So moving on to the final section of this session, which is sort of tying up a few bits and bobs to do with our terminology we use in MSE and thinking a bit about our psychotic syndromes and hallucinations. So you are in clinic and you ask your next patient, who is a 33-year-old female whom you're seeing for the first time, what she did yesterday. She begins to tell you she went out with her friend, before then talking about her friend's dog, before bringing up she's not looking forward to Christmas, purple is her favourite colour, her friend's name is Violet, and yesterday they went bowling and she had a burger. So which term best describes the thought disorder described in this presentation? Okay, a few more seconds. Perfect. All right. So the correct answer to this question is D, circumstantiality. So I will talk a bit about why this is the answer. So if we work through all of them, A is flight of ideas. So this patient, they are showing that they've got lots of ideas. They are showing flight of ideas, but flight of ideas doesn't tend to occur in response to a question, and the patient's attention can never be focused back to the subject at hand. Whereas here, eventually the patient has come round to telling you that she went bowling and she had a burger. Whereas the flight of ideas, they would have completely gone off in a different direction. And that's also why the answer isn't tangentiality. So again, although the patient has gone off on these tangents, they have come back to reach an appropriate answer, whereas with tangentiality, we don't see that an appropriate answer is reached. The patient's mood and affect obviously isn't mentioned within this stem, so C is kind of ruled out for that reason. And then D, so circumstantiality is when you do eventually reach an answer to the question asked. So I think I always used to get confused between tangential thinking and circumstantial thoughts, but the main differentiating factor is that with circumstantiality, you eventually come back to what you are asked about and what you're talking about, whereas tangentiality, you just cannot follow where they're going, and off they go. And then E, grandiose delusion. There's nothing to suggest that grandiose delusion is present. I've seen we've just had a question about whether pressure of speech could be used to describe this. And yes, it could. That was why I didn't put it as an answer, because then that would also be a correct answer. So yeah, the fact that this patient has got all of these things that they're saying, and you can imagine her delivering it in sort of a very pressured, manic way, with it being difficult to interrupt. So yeah, it would be fair to say that this patient is also demonstrating pressure of speech. So again, this is more a reference slide as opposed to something I will talk through now, but this is just some of the key terminology that we use within our MSCs and just what it means. So it's kind of grouped together in, first of all, some of the terminology to do with speech, then terminology to do with mood, and before moving on to terminology to do with thoughts. And we've got another page of it because there's lots of terminology that we love within psychiatry. And then finally moving on to sort of our delusional beliefs as well. If anyone's got any questions about terminology, feel free to ask, but if not, I'll just leave that there for you guys again to refer back to at the end of the session. So penultimate question for today. A 29-year-old woman presents to your clinic. You've met her several times and believe you've developed good rapport and relationship with her. But today she seems different in presentation and she tells you she doesn't want to come and see you anymore. When you ask her why, she tells you she thinks that the receptionist, who is the same person that has worked at the practice for 10 years, has been replaced by an imposter. She says that she can't trust this receptionist and doesn't want to come back to the practice as a result. Which of the following psychotic syndromes may she be displaying symptoms of? Okay, I'll just give you guys 10 more seconds as to not overrun with this session, as I'm sure you will want to go and enjoy your evenings. Okay, perfect. I'll close that one there then. So the answer to this one is E, which is Capgras syndrome. So it's quite rare we see these weird and wonderful psychotic syndromes actually in real life, but I know it's something that can get asked about in finals papers, so I thought I'd pop it in for you guys to just help. So Capgras syndrome was the answer here because the patient was describing that they thought the receptionist had been replaced by an imposter. Where you might have potentially got a bit confused is with the difference between Capgras and Fragoli syndrome. So Fragoli syndrome is where a person believes that several people have been replaced by one person who is in disguise. Whereas Capgras syndrome just refers to one person being replaced by an imposter, as opposed to Fragoli, which is where the person believes there are several people around them who are all the same person, but that person is in disguise. Again, some of the other syndromes which are quite different but quite rare are up there. And again, for the sake of time, I'll leave you guys to just sort of read through this, as I think this one is quite self-explanatory and hopefully not too difficult, and just a case of learning what features are associated with each syndrome. And question number 10 for today is: you are a final year medical student on your GP placement. You call in your next patient, who is a very worried 76-year-old male. He tells you that on several occasions he's heard a male voice and been convinced someone was beside him as he was falling asleep at night. He also described having experiences where he thought he could feel somebody touching his arm as he was falling asleep. He tells you he doesn't get these experiences during the day. So which of the following terms best describes his presentation? Okay. Again, just give you guys some time to have a read through and make your choice. Okay. Brilliant, we'll stop with that one there. So the correct answer here is A, our hypnagogic hallucination, which is easily confused with our hypnopompic hallucination. So both of these refer to hallucinations that occur around sleep. So a hallucination is basically a false perception that occurs in the absence of a stimulus, but although there is no stimulus and although it's a false perception, to the patient that feels so real and it feels like a true perception to them. So to the patient, a hallucination is experienced in the same way as any other normal sensory experience. And then the difference between our hallucination and our pseudo-hallucinations is with pseudo-hallucinations, patients feel like the experience has come from within the mind. It doesn't actually feel like something that has come from an external sensory organ. And that's the difference between the two. Hallucinations feel very real. The patient literally feels like they've been touched, or they literally feel like somebody has spoken within their ear. Whereas with a pseudo-hallucination, the patient has almost more of an awareness that that sensory experience didn't feel as real as if there actually was a stimulus related to it. So we can describe hallucinations in lots of different ways: first person, second person, third person. And then we also have some specific hallucinations that patients might complain of. So I think a couple of people might have got a little bit tripped up between our hypnagogic and hypnopompic hallucinations. So the way that I've always remembered it is that hypnagogic, so you've got the word go, G-O, in it, and that's because you're going to sleep. So it's the false perception that occurs as you're going to sleep. And therefore, by definition, your hypnopompic can't be when you're going to sleep, so it must be when you're waking up instead. So hopefully that will help you guys differentiate between those two. Perfect. I think that is the end of everything that I wanted to say. Thank you all so much for listening today. If anyone's got any questions, then feel free to shout out or pop it in the chat. And again, we've got our QR code to fill in the feedback form. And once you guys have done that, you get access to the slides that we've covered today. And obviously be as honest as you want in your feedback, because these sessions are run for the benefit of you. So anything that can be improved, please do let us know. And thank you all very much. I'll hand over to Anea to see if she wants to wrap anything up.
Thank you so much, Sophie. That was a really helpful session. If anyone's watching on YouTube, please do also fill in the feedback form. Because we leave them open for quite a long time, and it's really helpful. Now that most of you are watching on YouTube instead of attending live, it's still really great to get your feedback, so please do fill it in. And yeah, thank you very much. Thanks for everyone who came as well.